There you go. You should be able to.
Okay. All right. So just start off, this is just our journal club, CARES Journal Club. Our topic for today is going to be trauma-informed care for the violently injured patients in the emergency department. Oh, okay. I guess there's animation. I didn't think I had that. Okay, so trauma-informed care is best defined not by a single definition, like how a cardiologist deals with the heart, a trauma surgeon deals with physical trauma. Trauma-informed care is really better defined by what they identify as like the four guiding principles of trauma-informed care. The first, that trauma encompasses injuries that are not only physical. So this could be emotional, this could be mental. It can also take in multiple different domains of physical injury, including sexual assaults, gunshots, motor vehicle accidents. And it's important to recognize that even traumatic events that have happened in a patient's past life that weren't necessarily physical still affect their care that they might receive from us while undergoing another traumatic injury later on in their life. So here we go. The four principles that help define trauma-informed care. Realizing the prevalence of traumas and their routes of recovery. So this not only pertains to what kind of trauma is inflicted on a patient, but also what steps do you and they take on helping them to heal following their traumatic event. If the patient suffered from a gunshot wound, are you not only providing them physical health, but are you providing them with a place to stay, the proper emotional support to get through this traumatic event and to give them the proper coping mechanisms to eventually, maybe not go back to the life that they had, but leading a life that's at least safe and secure and free from having an additional traumatic event happening to them. Recognizing the signs and symptoms of trauma, which many of us as clinicians, we can misinterpret sometimes. We have personal biases against when patients are acting passive or seeming not interested in the things that we're offering to them or the questions that we're asking them. That may be just their defense mechanism or how they're handling their trauma in the moment. So it's important for us to really recognize those events and those behaviors. Building systemic care strategies, and this can be from the ground up, from when a patient first comes into the trauma bay, maybe not tearing off a patient's clothes every time they walk into the trauma bay or a trauma activation, providing them the appropriate emotional support when they're crying and not just assuming that they're being dramatic or having a personal breakdown over the event that they went through. Some people handle things differently, and while something may be small to one of us, it may not be small to them. So it's important to provide them with adequate emotional support, physical support, or if they have some kind of psychiatric issue, the psychiatric help that they may need at the time, and then working to prevent re-traumatization. So this could be a component of helping the hospital-based trauma intervention systems be set up, and really making sure that there's appropriate community outreach so that someone's following up with these patients after they've left the hospital, they're no longer receiving acute care, and to make sure that they're really kind of not only getting the acute care that they needed in the hospital, but also the chronic care that they need to address a lot of their issues later on. And this kind of plays into the next, talking about the prevalence of trauma. So in the US in 2015, there were 1.5 million non-fatal assaults. And this resulted in about 18,000 deaths, a little short of that. Interpersonal violence clusters in disadvantaged urban areas. Homicide rates among Blacks is 665% higher than whites. And this is a big issue because there's something perpetuating violence in our culture in certain areas that we're not addressing as caregivers, as doctors, nurses, that this is like a big area that we could intervene for. Recidivism can range between 27.3 and 61.5%. The article really talked about rates of PTSD. There's somewhere between a third and maybe 40% of patients. One study they talked about in Detroit, we were just or displaying symptoms of PTSD after just one traumatic event happening in their lives. And then there was another study that indicated that up to 80% of patients that were receiving the trauma bay had undergone, or not, I'm sorry, it was a survey, not the trauma bay. It was a survey of just patients in the population. I believe it was Detroit also, but that had experienced one serious traumatic adverse event in their whole life. And you think about, I don't know about any of you personally, but me personally, like I cannot even recall maybe one serious traumatic event that's happened to me up until I became a doctor and witnessed, some of these patients coming in and suffering from real trauma. And it really shows that emergency providers have a real niche, that they can provide care and really provide an important and profound intervention in some of these patients if we're able to help them, get through the acute event, treat their chronic symptoms from stress, but also to help prevent them from being re-traumatized. And this is just identifying some of the signs and symptoms of trauma. So there's positive and negative symptoms, as I've kind of alluded to already: hyperarousal, hypervigilance, aggression, anxiety. Some of these we may interpret as the patient not wanting care or not being willing to cooperate with care, but they can really be just the way that they're trying to defend themselves and make themselves kind of feel safe and secure in their own skin while they're undergoing this acute event. Withdrawal symptoms, depression, emotional numbing, loss of empathy. Loss of empathy may be something that we as clinicians can experience a little bit more of as kind of like a secondary trauma from being exposed to so many traumatic and awful injuries that can happen to our patients. Emotional numbing can be a very global thing that can happen between patients, nurses, any care provider. It's important that, especially as clinicians, that we're able to recognize these things in ourselves and understand ways that we can prevent that. Using de-escalation techniques to help patients, coming to care agreements, making sure communication's clear. Is it like a personal safety thing, making sure we're keeping a healthy distance from someone who may be displaying aggressive behaviors. And these can all be important tactics providing care for the patient. And then just understanding understanding biases. Everyone comes with biases. I personally took some of the implicit bias surveys that the article recommended and was very shocked by some of the biases that I carried, but including biases against people of my own kind. It told me that I had a bias against LGBT people, which kind of shocked me, but not everything's perfect, but recognizing those is important because it can lead you to identifying patients who are victims of trauma, such as gunshots or stabbings, as not being bad people. Not everyone who suffers a traumatic injury was, I guess, a fraction or a person within the violent action that happened. They may just be some bystander. You really want to avoid re-traumatization, so making sure to provide empathy and not using assuming language. The article came up with a really good example of not asking someone, what did you get into today, but just asking them, how did this happen? What happened? Respecting a patient's body language. Sometimes our patients they're pulling their blankets over themselves, they're trying to keep themselves covered. That can be an important sign that maybe they're not exactly comfortable with everything that's happening and they need a little bit more explanation as to why we're doing this or why we're asking that question. Recognizing trigger factors for patients. Sometimes, like in sexual assault patient, maybe they don't want to be stripped of their clothes. Maybe they'd like a little bit more privacy. Ignoring those factors can really cause more emotional trauma to the patient after they've already experienced something very traumatic. Providing psychological first aid, whether it's just talking and providing sympathetic statements or, setting the patient up with some kind of inpatient psychiatric help that they may need. Pain control, which I personally feel like can be something that many of us don't adequately provide during the moment, but providing pain control to someone can make all the difference. Sometimes the only thing they're worried about is the pain that they're experiencing in the moment. So providing that for them can really make a difference in the way that you're interacting with them and the way that their treatment course may go. And then just additional support resources, such as the hospital-based trauma intervention, having community outreach, providing emotional support, setting up outpatient psychotherapy sessions to maybe help deal with some PTSD symptoms. And that was really all that I had.
No, that was really excellent. I really thank you for putting that together and just kind of synthesizing everything that was in the paper and more. I think you brought up some excellent points and some, excellent solutions to some of the things that we see here. And I want us to further explore that. And I think what I want to do is read the vignette that's in the manuscript and then have that be our starting point. So just in case some people didn't have the opportunity to take a look at the manuscript, it starts with an introduction, and it says an 18-year-old man is brought to the emergency department by a private vehicle. He has a gunshot wound to the abdomen with an open wound near the umbilicus. So he's taken directly to a trauma bay. The patient is clearly upset. He's telling the nurses and physicians that he was walking on the street when he was shot by someone he did not see. The patient says that he has been shot once before and was taken to the same hospital where he received bilateral chest tubes without any sedation. The physician nods, records in the medical record that the history was limited by the patient's lack of cooperation and agitation, and proceeds to intubate the patient in preparation for surgery. Shortly afterward, several of his friends and family members arrive asking to see him. So to start off our discussion, I just want to ask, just reading that small vignette, do you think that treating physician practiced trauma-informed care of this violently injured adolescent? He's 18 years old, and the definition of adolescence, according to the American Academy of Pediatrics, is 11 to 21. What are your thoughts? Feel free to come off of mute or just speak.
Hello?
Yes.
Hello? This is Marshall Florent. I'm calling from the car, so I apologize. I don't know if it was trauma-informed necessarily, but it's very usual care, I would say.
So you see this commonly? What was usual about it?
Well, so what I would say is that, it's a situation that's, kind of hurried and intense. And I think as providers, a lot of times we just kind of try to kind of just get to business. And at the same time, there's a recent trauma, there's family who wants to be involved, and maybe in our own stress and the intensity of the moment, we try to suppress that a little bit and just kind of go through our protocol without I would say without thinking too much about the immediate trauma and that's going on. So I think that is probably a fairly common thing to happen, and it's something that I've witnessed.
Yeah, me too. I think that we do get in our routine. For us, the ABCs of trauma are supposed to come quickly, and we don't necessarily think about the trauma that's happening in the moment or the trauma that the patient's experienced in the past. It said that he's been shot before. He's been to the same hospital. Yes. Hey.
Yeah,
April.
that's actually what I was about to say. Hi, it's April Grant. I'm one of Randy's partners, one of the trauma surgeons at Grady. But I think what's a little disturbing, two thoughts come to mind in this 18-year-old who's now had, unfortunately, two episodes of violence in his experience. One is that I think as providers, we need to be very cognizant that their previous experience is going to influence their behavior. And so, Randy, you, me, and Jonathan had those back-to-back, like repeat gunshot wounds to the abdomen on new re-X slaps. And
Right.
all three of those patients behaved in a way that you could see their previous experience influence their behavior. And I have seen that over and over again, and I think you can't discount that. I'm disappointed in the vignette that the physician went and documented the patient was agitated and uncooperative. It sounded like he was actually trying to help. And while I agree with Marshall that sometimes in the heat of things, you're trying to do your stuff, when you're writing your note, like that's not in the heat of things. And it's disappointing that it would be documented in that manner, because the guy was probably scared and trying to cooperate, even though he's afraid and saying, hey, this happened to me before. Those are the two things that sort of come to mind for me immediately with this vignette. And just being so cognizant that that previous experience is going to color everything you do and every reaction they have.
Yes, I 100% agree. Other thoughts? I want to touch on the language piece that you mentioned a little bit. I want to hear what other people have to say directly about the vignette.
Hey, Randy, this is Stan Sonu. I agree with everything that's been said already. And I wanted to point out, I think there's something, and I'm no EM doc, I'm not a trauma surgeon, I'm an internist, pediatrician. So obviously I'm not in the acute setting like you all are, but even within our own specialties, my own like internal medicine and pediatrics, there's something about medical culture where when we see a person who's acutely agitated and we don't really know them, we, in the back of our minds, we just attribute that, it must be something mental, like some kind, they're quote crazy, or we sort of dismiss that behavior as being irrelevant to the current situation. And I think that's part of what's happening here. And it's not the fault of any one person, but I just think it's kind of endemic in our culture, probably multifactorial where it comes from. But I think there's something about our medical system, our healthcare culture, where we're quick to attribute problematic behavior as some sort of inherent dysfunction in the patient. So I thought that, that to me, that's what stood out in the vignette.
Yeah, I think also too, we tend to treat it with physical restraints or with medications, and not necessarily with talking to patients and figuring out why it is that they are behaving in the way that they're behaving. I think we act without really understanding the full extent of what's going on. I think you bring up a good point, because we all have taken care of violently injured patients, right? We're talking about the acute setting, but some of us take care of patients in the ED, the OR, the ICU, the med-surg wards, or even, as outpatients. And I just want us to take a moment to reflect how our patients who have been violently injured or traumatized, how do they manifest their signs and symptoms of trauma? I mean, clearly he was afraid. He had been in the same situation previously. And he was a little bit agitated, is what this says. And I say agitated in quotes. But think about the ways that people manifest their trauma in your clinical setting. Can people comment on that?
I've been really, really surprised, actually, as we have been trying to implement more of these conversations, how open folks are about their experiences when it's addressed. Like, whenever I have someone who we're sending home with a gunshot injury but has been like washed out, I will often like kind of go over some of those expected symptoms of acute stress disorder, and specifically saying like, hey, you may be really on edge, and may have a hard time, like maybe with like relationships that are important to you. And the number of like young men who like we have no previous connection are willing to be like, oh yeah, actually, like, unfortunately, the last time this happened, or I got shot like that many years ago, and I have been having a lot of that, or have recognized that in my like relationship with my girlfriend. It's just remarkable to me how little of a barrier it really is to make that connection, but how much I have an aversion to like kind of cracking open the seal, like a little bit of a fear of it.
How do you overcome that fear?
I make excellent friends like you.
That's not the right answer.
I think sometimes the challenge is just not knowing what you can do. You know, I mean, you can talk to people in real time, but maybe not knowing what type of follow-up people can access and you can refer them to. I think that would make such a huge difference in, you know, like it's easy for me to say like, hey, follow up in the trauma clinic, not only for your injury, but also so that you can talk to your provider more about this. But I think sometimes that's the barrier, is like, it's hard to talk about because if you don't feel like you have good solutions, you just feel kind of stuck, and then it's hard to sort of end the conversation.
Yeah, I agree with that. I mean, it's like one of those things, you can't screen for something and then not provide resources. That's actually, in my opinion, a little unethical, or maybe a lot unethical. But I do want us to discuss barriers to trauma-informed care. So I love that, Amy, you said that that's a barrier. So if you don't have the resources in place, you don't know how to have these conversations. Are there other barriers to trauma-informed care or practicing trauma-informed approaches when you care for violently injured patients in any setting?
I mean, off the top of my head, just indoctrinated medical care is one big barrier. I feel like I face this all the time with new residents that come onto service. The first thing they want to do in the 18-year-old low-speed MBC is cut off all their clothes, and I'm like, you don't need to. We can take it off safely. You don't need to just go right at that and be like, oh, but you know, I was always taught this is the way I had to do it. And a lot of times that I feel like a lot of residents always respond when they do something that's kind of like that very classic ATLS protocol, classic trauma surgeon type of attitude, that's like, this is the way I was told to do it. That was the only way I found acceptable to do it. And I feel like sometimes a lot of things in medicine end up going back to kind of that old medical attitude of like, I'm the doctor, this is what we're doing to the patient. Kind of like paternal medicine's still a very prevalent aspect of our society. Just, I don't know, I guess I don't really have much of an ending after saying that.
Yeah. No, but I think you're right. Actually, from this group, we were actually able to change a little bit of culture, but not too long ago, they made every single domestic assault or intimate partner violence case like a level 2 trauma. And as we all know, that when you have a higher level of trauma, which usually indicates a higher acuity, you get a bazillion people in the room. And that's the first thing that people want to do is they go through their protocol, but they're moving so quickly, they're cutting off clothes. And there are a lot of people staring at someone who may have just been assaulted by an intimate partner or even sexually assaulted, that likely doesn't want a bunch of people looking at them while they're naked. And, you know, and then also they're incurring extra cost because there are costs that come with being a level 2 trauma. And, you know, we spoke up. We said, you know, it doesn't seem like just being a victim of intimate partner violence should lead to all of these different things that could be re-traumatizing. But you're exactly right. It's just this indoctrinated practice that, and I think that people want to do the right thing. The intent was to, you know, expeditiously treat the patient and figure out what their injuries are. But you have to have intentionality with everything that you do and understand that you can re-traumatize a patient. So I think you're spot on.
And I just want to chime in too. I think that also comes that like dogma. I agree with you, Dustin. I do think it's a culture that needs to change within medicine, but I think it's also incumbent upon us because it's also a lot, like you said, trainees. And I think they just follow protocols because they don't understand. And that's such an opportunity for us to provide education at that moment and say, hey, listen, like there's nuances to everything we do. And while yes, maybe, you know, most level 1s and extremists need, you know, everything taken off quickly and a rectal exam and every other invasive thing you could possibly think of. To your point, Dustin, the very stable 18-year-old who's a level 2 may not. And that's, I think it's incumbent on us to provide that education and use that teachable moment for the trainee who's not as in tune with maybe some of the finer points of trauma-informed care.
Right.
I wanted to also chime in and Stan might be surprised by this, but when I first came to the section and I gave a talk on trauma-informed care, one of the faculty members literally yelled, "Send them to psych," before I even finished my first slide. So there definitely is part of the culture, at least maybe in internal medicine, primary care, at least at some point, that it's kind of not our problem or it's other people's problem, or I don't quite know how to deal with this, so let me send it to somebody else. Kind of a dismissive culture about trauma. But at the same time, what I'd like to say is, through the work of us giving talks, Stan gives talks all the time, I give talks on occasion throughout the section, and talks that's just going on throughout the university on trauma-informed care. I really think that the culture is definitely changing. So the more, I think, having it being part of our lexicon and discussion on a regular basis is really helpful in turning the culture around.
Yes, thank you guys for all that you do. I mean, because it's a heavy lift, it's a culture shift, and that means it takes a lot of time and it takes a lot of energy. Mike, I see that you're coming off of your mute, and I was going to ask you to chime in because I know that you're doing a lot of heavy lifting in the emergency department.
Oh, yeah, actually, I just wanted to keep building on what this discussion has been about the kind of medical culture, in that I also think that there's a lot of internal work we have to do. Actually, I was a little bit called out during like a presentation I gave once by one of the authors here for like having trying to shut everything down and getting on to the next talk with a very sort of like, okay, we're done here response, like the next speaker's coming in. And the way that it like kind of dismissed a little bit of what everyone was trying to bring into the presentation. But I realized that what I had done is I like switched into my doctor voice, where like in settings of uncertainty, what I want to do is I want to provide some version of direction and order. And that actually that practice may be contributing to an inability to connect to patients or re-traumatization in a way that it like takes away agency or autonomy from patients in order to make myself feel better. And so what I've learned is that there's a lot on like the internal side of this as well that I have to do to show up well in these settings.
Yeah, I just wanted to add on to that, Michael. Like, I think one of the things I noticed the most as far as a barrier to trauma-informed care is, like personally and also within learners and residents, the more tired and exhausted I am, the less sort of capacity I have, emotional bandwidth I have to, I don't think tolerate's the right word, but to be able to absorb and really understand within context what's happening. And, just like the thing about trauma is that it, if it's happened to a person and an experience has become traumatic, there are the phrases in the article, there are predictable behavioral responses. And that's not just true for patients, but it's true for us as well. And so I think there's kind of this inverse relationship where the more tired we are, or maybe it's a proportional relationship, the more tired we are, the less we're able to have capacity to understand a person's behavior in context. And what we do instead, the more tired and exhausted we are, is we react to the first emotion that we see. So if a person is like agitated and they're lashing out because they're in pain, or they're hypervigilant and they're in survival mode, like their brain is telling them there's a grizzly bear in the room, and they are acting in that way. Their phenotype is agitation or hyperarousal. If we're not at our best, then we're going to react to that, and that's just because we're humans, not because we're bad people or we're bad providers or we're necessarily burnt out, but it's a day-to-day thing. So I think just our own well-being has a lot to do with our capacity, our ability to be trauma informed.
I 100%.
That was well said.
Yes, exactly. I was going to say, we do 24-hour calls. And when we get some of these patients at 2 or 3 o'clock in the morning, and even me, like having a trauma informed lens, my bandwidth is definitely shorter. It is, it really is. And I think that was incredibly well said, because I experienced that personally as well. Hopefully we move to 12-hour shifts soon. Or like the ED, I think they do like 4 or 6-hour shifts or something like that.
2, yeah. We come in for our lunch break. That's great. I also think that, I don't want to jump the gun beyond just like this clinical vignette, but when we think about that beyond like our personal bandwidth, but into the system, and like how does the system have the ability to maintain a trauma-informed lens when everyone's getting stressed? That's something I've been thinking about a lot recently. The word I've been using is generosity, just because I feel like that kind of like ability to have space is kind of a generosity that I have less of when I'm really tired or stressed. But I imagine that systems that reliably perform trauma-informed care have to have some extra bandwidth of generosity built into the system.
Stan, I want you to respond to that.
Oh yeah, I mean, absolutely. And I think for any system, any leadership that's interested in implementing trauma-informed care, they should not start with patients. They should start with staff. They should start with the internal people working in that system. Because there's actually literature on it where it's failed when you have a leadership that's really enthusiastic. They hear some talks about trauma-informed care, they want to implement it, and they go straight to the patients. And without realizing that if they don't support the emotional well-being of their own people, they're not going to execute anything that's related that resembles being trauma-informed. And I think one tangible thing that you already mentioned, Randy, is the shifts, going from 24 to 12-hour shifts. I think that could go a long way. And it might be more expensive for administration to do that because they might have to hire more people to cover all the shifts. But again, I think it's worth it. I think you'll see the benefit, you'll see the return on that investment with greater patient satisfaction, better patient outcomes in general.
Agreed. Are there any more thoughts? I wanted to circle back to what April was mentioning about word choice. It's something that I'm really passionate about. But before I go there, is there any last minute thoughts about this discussion? Yeah, one of the things that it really actually bugs me is that we use language that, and sometimes it's inadvertent, but we use language that can re-traumatize patients. It can criminalize patients. And I'm really very much hyper-focused on the language that I use in the patient's presence, but also in the presence of trainees, because I think our words have the ability to heal or hurt. And, there was some talk in this manuscript about word choice, referring to patients as gangbangers, calling the trauma center a knife and gun club and things of that nature. But I wanted to just ask, has anybody noticed any language being used that could be re-traumatizing to patients, and how did you deal with it? Were you the one using it, corrected? And what could, like in this vignette, like how could the doctor have documented the agitation in a different way that wouldn't have been so astute?
See, I took a lot of issue with what the was documented in the vignette. I feel like the doctor used his language as a way to justify intubating the patient without appropriately discussing the care plan with the patient at the time. Clearly, the patient had was stable enough to communicate why he was concerned and agitated. And then the clinician kind of tossed that to the wind, documented the patient was agitated, and then seemingly used that as a way to intubate the patient and bring them directly to the operating room. I feel as though that could have been alleviated simply by the physician saying, listen, you're in a critical state. We need to take you to the operating room. You know, I have these concerns X, Y, and Z about why I think you need to be intubated. If you're okay with that, we're going to proceed with that now.
Yeah. And I also think adding to that, saying, I know that you're concerned that you didn't get pain medicine the last time. With this intubation, you will be adequately treated for pain and given sedation. Because like someone already mentioned, pain sometimes is like at the forefront of people's minds and they can't think about anything else.
I think there's also a possibility that the clinician doesn't have a concept of what else that could be rather than agitation. So like even like less malaligned, even one of the things in like another study I worked with in residency was like residents would attribute all of the difference in their understanding of a patient's disease and the patient's understanding of like what they wanted to do to like a lack of medical knowledge or medical education rather than a difference in values or difference in priorities. And I think that really reflects that like that's the one thing that we've been taught in med school as like what could be different between us and the patient is just like education rather than actually different values. And I think that's a little bit of what could be happening here, where the clinician just is able to interpret agitation as like either medically induced or psychiatrically induced, and not like you guys were describing related to self-advocacy.
Yeah.
So I think that's a very good point, because I also kind of like question, like, you know, what's the environment? For instance, like, is there, with a lot of gunshot wounds, like there'll be a police officer around, right? Is that contributing to the patient, you know, being less cooperative, right? And did the physician try to get a social worker to try to talk to this patient, right? And maybe this patient would have been more willing to talk to a social worker and not a physician, right? So I wonder if, you know, these options were, if the physician looked at these options.
Yeah. Brian is a biomedical ethics student who spent some time at Grady working with the trauma team. So Brian, I know that you've seen a lot, and you know, you probably can attest to some of these experiences that patients have undergone. We don't know what happened in this clinical scenario, but it's true. There are oftentimes police officers or law enforcement agents that are around, and there's a huge mistrust when the police are around, for sure. You can tell in people's behavior, they don't want to talk, you know, and it's a hard balance too for us as clinicians. Like sometimes getting information in the moment or, you know, pretty quickly is helpful to capturing an assailant or, you know, whatever the case may be. So you don't want to impede that process, but you do want to respect the patient. And so it can be a hard balance for the physician to achieve.
Yeah, I totally agree with that, Randy. I think the buzzword for me that, you know, I try not to let get under my skin, but it does, is like drug abuse or addiction or addict, because it really misunderstands the nature of substance use. From a trauma-informed lens, substance dependence, substance use is coping. It's coping until proven otherwise. It's not a lack of willpower. It's not because someone is bored. It's not because someone has poor morals. But they are running from pain and they are trying to deal with that by self-medicating. And so when you label someone as abusing drugs, that sort of implies that they don't, you know, F the world, I'm going to use these drugs. I don't care about anybody. And it's sort of, it's very, I think, disparaging and really misplaced sort of diagnosis. It's a misdiagnosis, essentially. So that's one of the things that I try not to let get to me, but it does, and certainly reflects, I think, like as Mike was saying, like just a knowledge gap across the board.
Yeah, I have those buzzwords too. Mine is repeat offender. It was mentioned, we've had several people who have come back with recurrent injuries due to firearms, and repeat offender is just criminalizing in so many different ways. And so I really think that I try to avoid that term. Uh-oh, the kids are here.
Yeah.
Hi.
The other thing I was going to add too is, oh my gosh, they're so cute. I was going to add, it's not so much word choice, but something I've noticed that that we do in internal medicine and our nurses on medicine floors do as well, is the first time a patient, it could be a very contentious encounter. Maybe they act out, maybe they are verbally abusive, and that's inappropriate in the moment. And then an FYI flag drops, and that FYI flag is the first thing that pulls up every time you open that patient's chart thereafter. So I have seen FYI flags that date back to 2016, when a patient came in acutely agitated for whatever reason. What relevance does that have in 2021? So I kind of make it my practice just to delete those when I see them, because I think they only served, after some time, they only serve a purpose to stereotype and sort of prejudge a person who, anybody who comes to the hospital, especially the trauma bay, that is one of the worst moments of their life. That's one of the most stressful experiences of their life. And so to judge them and for one encounter to put this FYI flag in that is indefinite, that doesn't expire, I think is something that does net more harm than good.
I'm gonna just jump in on the word choice as well. One of the things that I pay attention to is alcohol abuse is something we drop so quick, but sometimes I talk about this with residents. Is is this alcohol abuse, or is it more a dependence? Is this person really abusing? Sorry, that's my dog. So is this person really abusing alcohol? I think, or sometimes it's just alcohol use. Maybe they have, a certain amount of drinks per week, but it's not something I would describe as excessive or abuse, but they'll drop the term so fast. So I think those kind of labels, are we really using the definitions correctly, is something to think about. I always kind of discuss that with residents at times, because I think those labels or the terms you use matter.
Bree, were you getting ready to say something? I see you came off the mute.
Yeah, I was just going to ask another question that was kind of related, because when in my time in different ERs and different trauma bays and different systems, doing research and shadowing, I guess what would you all advise somebody who's up and coming to say, because you want to advocate for the patient or fix the things, or make it so that these terms aren't used anymore, or the patient is not viewed or labeled in a negative way, but it's also you're in this position as to how do I even change, what's going on, or correct somebody?
I think I would start off by saying, just be aware and be empathetic, right? You have to understand and recognize that people manifest trauma in certain ways, in different ways. And if you're trying to avoid re-traumatization, your words really do matter. Labels matter, your behavior matters, but you have to have that wherewithal, the knowledge to know that there could be several manifestations of trauma. And until you really dive deep into the root causes of why someone is there or why they're acting the way that they are, try not to label them or judge them in any way. And it takes a lot of practice, right? We're not on this call saying that we're perfect. I'm definitely not. It takes a lot of practice. And you have to check yourself, and you have to be surrounded by other people who feel similarly and can check you if you do something that's out of line. That's the only way that we grow. And I think it's a wonderful question. And I don't know if we have any trainees on the line beyond Dustin, but I would love to hear from them, from their perspective too, how they're taught by their faculty.
sometimes, and I feel like this is a point that can be lost, especially among clinicians who are trying to take care of others so often, is that you also have to learn to be forgiving of yourself and be careful of what you say to yourself about yourself as well, because it's something I'm very guilty of, is I talk very badly about myself to myself. And, you know, I think part of that would be breaking the cycle of thoughts. And if you can break the cycle of thoughts with that, or if you can even break the cycle of thoughts or biases you have towards loved ones or others around you, that can have a lot of meaningful impact into what you're saying and what you're doing to strangers as well.
I just wanted to shout out, y'all. I'm in the car, so lots of background noise, but I so resonate with what you just said, and just wanted to say one thing. This idea of us forgiving ourselves, I think, is a really huge idea that no human being, I think, does well. I think we are all the most critical of ourselves, and being able to forgive or to even call ourselves out. You know, sometimes I try more now to pay attention, like to listen to the words that are coming out of my mouth, if that makes any sense. And sometimes as it comes out, if I'm really paying attention to it, I can kind of, in my head, I'm like, oh, wait, that. And so even being able to kind of call myself out, I think, and forgive myself for it, or identify where I was not as trauma informed, is such a great skill for me to not be too hard on myself, but also to teach our learners that we are growing as well. And it's okay to correct and catch it.
Yeah, I'm just going to add to completely agree with like really going easy on ourselves and having some self-compassion. I think that really would go a long way for our system to be trauma informed. And then just to go back to your question, Bree, like if I were a learner and my upper level or supervisor said something that I thought was really inappropriate or disparaging or not trauma informed at all, I don't think I would try to embarrass them or call them out on the spot. I think that could actually potentially have the opposite reaction, but more, you know, in a private setting when there's not a whole lot of people around, just in confidence, just take an approach of curiosity and inquiry of, hey, you know, I noticed like one thing that stuck out to me is when you said, you know, like that's drug seeking behavior to the patient. And I was just wondering like where that came from. Is that something that I should say as well? So just kind of taking this approach of being curious in asking questions could go a long way. And you know, believe it or not, I think most people will get the hints and they'll know, okay, like I see where you're going with this, and it was a moment. It's not my proudest moment, but you know, here are the reasons why that it came out like it. And if I could go back, I wouldn't say it that way. And sometimes they might say, why do you ask? And then that could be your window to explain, well, you know, there's this thing called trauma-informed care, and then, you know, you can kind of give your spiel there. But the thing that I would try to avoid is calling out someone in the heat of the moment in front of the patient, in front of other people.
Yeah, kind of along those lines, when we were thinking about how does a department do it, specifically like in the ER, obviously it's really easy to recognize when it's not done well, like those really bad moments, but how do you help people like actually do it well? We try to just orient ourselves around the idea that like everyone actually wants to get like the highest quality of care, and start with that like kind of shared understanding, and then give people examples of people who do it really well, rather than try to just go after all of the times it's done poorly. So then you kind of gradually build a culture around it. But the one thing I try and keep in mind is just like, if people do get called out, what they're losing is a little bit of their identity of like being a really good care provider. And so you kind of have to just make a little bit of space for that loss as they learn.
Do you want to talk about your ugly sweater award? You're on mute.
I mean, mostly I just want to say the ugly sweater award. But that's just like the underlying idea. We're trying to like make a monthly recognition program for folks who demonstrate what trauma-informed care can look like. And then we like send it out to all the departments involved, trauma and ER and the nursing staff and stuff like that. And they get to take a picture with my great dead aunt's ugly medical sweater. So it's a win.
I think that's really nice to reward, you know, people that are doing it right. It changes culture for sure. So I really love that. I want to be mindful of everyone's time. Thank you so much, Stan. I see you have to jump off, no worries. If there are any last minute thoughts in the last 2 minutes that we have, go for it.
So I have a quick question. So I think this paper was very good at kind of like telling what the problem is, but I still have a lot of questions about like policy and guideline and things like that. Like, how do you kind of like, what ways can we make this mandatory? And I think that's like one of the biggest questions I still have. And I don't know if you guys have thoughts on that. Maybe that's for the next meeting or something.
Well, my initial thought is that it's really hard to make something mandatory that is, I still think is a little bit evolving. We, you know, are still learning about trauma-informed care and really solidifying what it is and how we can best take care of patients. And I think as this grows to be more widely known and widely accepted, then it will be something that as a system we can implement. I will tell you that right now at Grady, there is a big push for trauma-informed practices at the systems level. And one of the leaders is really, you know, really standing behind this and trying to come up with a curriculum that, like Stan said, starting with the faculty and staff and coming up with a curriculum that exposes people to trauma-informed care and it shows them what it can look like if we are a trauma-informed institution. And I think that once we have that going for us, it'll be a lot easier to kind of implement some of these practices down to the patient level. So I think it's coming. I think having more of these discussions and have it be as multidisciplinary as possible is going to help to spread the word.
Also, Brian, I love that was your question because that was also Amy Zeiden's question when we like looked at this back in the ER subgroup. Because she was like, I love this, but also like, what are we supposed to do now? Which actually I think does represent, like I understand, like this is new in a field. Like we're kind of also like making the way.
Good job, baby. Oh, sorry, I'm not on mute.
I love that we're upstream of it though. I just want to say, like, the more we do these kinds of things and get the message out at kind of the grassroots, you know, boots on the ground level, the easier, you know, it's always better, I think, when Grady and our health system supports initiatives as well. But as we all know, sometimes the top could support it and it's very hard for it to trickle down to the bottom. So I think us doing this groundwork can kind of help get it planted so that when the system is ready to support it, people are already engaged and kind of ready to, you know, hit the ground running with the momentum that the system can provide.
Whoa!
I love him, by the way. Buddy, I'm so happy you got to join this Zoom. Are you taking care of mama?
Right. I know I was trying to come off of mute so I could say thank you guys all so much, but wow. Yes. Someone wants to tell me their alphabet right now. So
wow. I want to say thank you for you. You know, that's his thank you right there.
You too.
Okay.
My son's like, he's so cute. I'm like, dude, it's a ditto. We are all so cute up in here.
Yeah, I love it. Thank you guys so much. I thank you guys for joining this first journal club. I know this is going to be one of many. I look forward to the next discussions. And Bree, when's our next meeting?
And I want to say thank you guys again for joining this. It was a great discussion. We submitted too late to be on the Grady's weekly newsletter, but we should be on the next one with our next Journal Club meeting. Our next CARES meeting is the next Tuesday at 3:30. I sent out the invitation today. I'll send out like the email with the agenda and whatnot, if not later today, tomorrow. And I also created like an Instagram for CARE, so we could be like, you know, so if you guys, I'll like put it in the email, and I'll also try to upload this recording to the Instagram IGTV. So that'll be a way that we can kind of disseminate the things that we're doing.
I love it. I'm not really on IG, so maybe I should step my game up. What about Twitter? Can we do Twitter as well?
Yeah, definitely. I think Twitter would be great. And then on Twitter, we can like post the articles and then like maybe discussion points. And, you know, people, there's a Med Twitter. If you guys haven't seen Med Twitter, they like to discuss things as well. So that might be a good like talking point, you know, to like spread the word of the things that we're doing.
I love it. Thank you so much.
Bring all the other updates in our meeting next week.
Thank you so much, everyone. I hope you have a great evening.